What I want to do in the time we have today is give a brief introduction to the transition, give you a little history on some tools we developed to help with this issue, and they're divided really into three sections, and that's a structure that persists. So we'll talk about some general tools, some physical health tools, and then some tools that help with behavioral and mental health challenges, and then some time for questions. So we've heard a lot about transition from pediatric to adult care, and it really, to my mind, looks kind of like this. There just isn't a lot there. You're jumping off the cliff, and it is getting better, but we need to do better. And so one piece of this can be the IDD Toolkit. Quick overview of Intellectual and Developmental Disability Medicine 101. I'd like to really try to achieve two things. For those of you on the pediatric side, I want to give you some tools that will help as you extend your practice, because you don't have, the buses aren't here yet. The buses full of providers aren't here yet. So what are we going to do? So here's some tools that might help you, but they may also help you with some of those conversations with physicians, nurses, therapists, and other disciplines on the adult side to get them to see this is not quite as mysterious as they might think. Interestingly, the woman in the upper left-hand corner there examining that man's ears, I'll mention her again in a moment. That was Helen Benge, and she did what, in my mind, is a landmark study in this field. It's old now. It was published in 1995. But she basically carefully examined a couple of hundred people and had a control group. 95% of those people had medical conditions. On average, they had 5.4 diagnoses per person. They saw their physicians more often, but over 40% of the conditions weren't detected before she examined them as part of her study. Even those that were detected weren't adequately managed. A significant proportion of the folks said there's no problems, and a part that's always alarmed me, because I often rely on family members and staff and others who might accompany the person, almost a quarter of them said, no, the person is fine. And this is in people that had 5.4 diagnoses each. This doesn't project well, but I'm always trying to convey some of this information in digestible bites to residents and nursing students and medical students. And I always think about 1, 2, 3, 4, 5 as a way of kind of remembering some of this. So if we think 1% of the population has an intellectual disability, we have good evidence that they have 2 to 3 times the physical health problems compared to the general population. Before I came to Tennessee, I said they get 4 times the number of prescriptions, but we have a unique situation in Tennessee, so I don't know what that number is. And we know that 40 to 50% of adults with intellectual disabilities have either challenging behavior or a psychiatric diagnosis. My thanks to Dr. Warren from Tennessee Department of Health for sharing this, and this is old data, 2010, but that just maps out, I think, graphically our prescription drug problem here in terms of looking at how many pills of each of those are written for each Tennessean over age 12. Adults with intellectual disabilities are complex. They have a different prevalence of problems in addition to their multimorbidity. So if you take epilepsy as an example, about 1% of the population has epilepsy. If you have a mild intellectual disability, about 20%. And if you look at people as you move along that continuum from mild to moderate to severe and get to a profound level of intellectual disability, it's 40, maybe even 50% of those folks have epilepsy. Lots of comorbidities. And health presentation is atypical. And one of the most distressing things you find with adults with intellectual disabilities is they do not show the same pain behavior you or I might. And the tragic part of that is, without experience, people will sometimes assume, oh, this person doesn't feel pain. No, that's absolutely not true. Excuse me. They do not experience and show pain behavior the way someone without a disability might. I think of a man who was taken for a walk one day, a fairly long walk, and became increasingly agitated. So I saw him after his walk, examined him, and he had a rectal abscess that would admit half my fist. I can give you all sorts of examples, just horrendous pain. And I feel guilty knowing the patients I've left in pain because I have, not deliberately, but I haven't been able to find the source of that pain quickly enough. You know, there's often criticism that in some centers, people get poor care because they present late in an illness and sometimes die from preventable complications like bowel obstruction. We're talking about a very heterogeneous population here, and I'm unfortunately, in the interest of time, lumping people together, but it's different having a mild disability. It's different at the other end of the continuum, having a profound level of disability. So presentation can be different, but again, people may not show pain until they're really late in the course, and sometimes it's too late to even treat. I have a case of a man, and actually it's on our department website, where this man presented with 4 hours of fever, nothing else, no cough. The fever went away without treatment. Labs were done, and it was only that care provider, the frontline staff person, knew he was not right. And she was right, he wasn't right. And with that tantalizing introduction, I'm going to stop there and you can have a look and see the rest of the story. We have evidence that if you have an intellectual disability, you die 13 years younger than the general population if you're male, 20 years younger if you're female. And that's an interesting reversal of the general population where women outlive men. Oops. So let's talk about practitioners. And we heard about that earlier this morning, but it's not uncommon for healthcare practitioners to have little training or experience, have difficulty communicating with people who don't use language. They may be used to that in children and perhaps in older adults, but that's not something that you get a lot of experience with. There's a literature that suggests the attitudes of physicians, and indeed nurses and some other disciplines, is not what it should be when it comes to providing care for this population. And when you think about it, maybe that's not surprising. Society tends to devalue people with disabilities, and why would any group not be part of society? Especially without that experience. It's that experience and coming to appreciate the joy of looking after people and appreciating each unique human being that helps dissuade wrong attitudes. There's something called diagnostic overshadowing. Stephen Reese coined that term, and basically it's attributing everything to the person's disability. Oh, that person's just sitting off in a corner because they have an intellectual disability. And that may be true, but that logic means you'll miss a depression that could be very treatable. And it's a lot like saying, oh, well, you're having these health problems because you're getting old. Last I checked, we're all getting old. But it shuts off your thinking in terms of finding treatable conditions that can improve that person's quality of life. There's an interesting paper in the family medicine literature that quite explicitly family docs talk about feeling overwhelmed with lack of training and experience and these very complex folks. We've heard about workload issues. We've heard about reimbursement issues. What's the size of what we're facing in Tennessee? There's an estimate of our population. If we take between 1% and 3%, we're looking at between 65,500 to almost 200,000 people. If we assume a PCP panel of 2,000, that's 20 to 60 patients I might have in practice. And if I think about challenging behavior, I'm only going to see 8, at most 30 patients. I'm not going to develop a lot of expertise in my practice if I haven't had training before I'm in practice. Sometimes it feels a little bit like this. If you can't read, the bottom says, I can't even pronounce what you've got. And that's the paper I mentioned. It's a fairly recent paper, and it talks about educational needs of family physicians. In the past, people received care in large congregate settings. Places like this was built for 2,500 people. At its maximum, had 2,800. So there was crowding as well. And that closed. That was a place actually I worked. There weren't that many people there. In Ontario, Canada, the government decided they would close all institutions by March 2009 and recognized that the community was not prepared to look after people. And remember, there's a big barrier that's not present there. It's a single funder government health insurance. Everybody's covered. That was not a barrier. So a group of people came together, and in 2005 there was a colloquium to develop some primary care guidelines. These have been updated, and you've got the reference actually to that paper in your handout. There are 31 guidelines. To the extent that there is evidence, they're evidence-based. 9 of them are on general issues, a dozen on physical health, and then 10 on behavioral and mental health issues. So the reference is there. And there's a fair bit of literature. There's only one problem with those guidelines, though. There's some pretty good evidence that physicians, at any rate, don't follow guidelines. So that was a bit of a stumbling block. All the work into, and this is the second iteration of those. And I've just included those, but I'll show you where you can look those up after. And so there are things like, we know there are disparities. And actually, Surgeon General's report from 2002, there was a recent update, and sadly, things have not changed a lot in terms of those disparities in the interval. It's helpful to know etiology. Pain and distress, you've got to remember it can be atypical, and you may just see challenging behavior like that man with the ischiorectal abscess. Abuse and neglect is a huge issue. And when I see a new patient, I always wonder how much of what I'm seeing in terms of behavior reflects post-traumatic stress. And also, what abuse did people receive in the healthcare setting? It's difficult to take all the time you would like to desensitize the person for a procedure or even a visit. I think of one woman, after 12 visits, I got her from trembling outside the clinic to coming into the waiting room, to coming into the examining room, to actually sitting on the bed. I figured another 3 or 4 visits, she actually would be relaxed enough to participate in the examination. And my hope was, from that point forward, that relationship would continue. That only happened because when she was ready to leave at each of those previous visits, it was over. When I first started out, I was more directive with people, and I learned quickly that all it meant was people wouldn't come near me for 6 months because they remembered their first encounter with me. Now, there's some problems with that. Clearly, if there's an urgent health problem, the situation's different. And we're back to a reimbursement issue in terms of who's going to have 20 visits before you even do something with a patient. Obesity, vision, and hearing, those can be insidious in their onset. So you've got to certainly think of those. Dental disease also can be a really significant problem. I remember a patient who I was working up for a change in behavior, and sometimes that's all you find is a change. And that's not really helpful sometimes. And, another interesting aspect that makes this work so intellectually stimulating is for physicians and nurses in the room, you take a history, you're already starting to think this is likely this body system. By the time you've finished your examination, you at least know what body system. I can think of a number of times I've taken a history, I've examined the person, and I'm standing there thinking, I don't have a clue what body system I'm even thinking about, just because of the complexity and how atypical the presentation may be. If you like problem solving and challenges, it's wonderful. Let me counter that with another quick example. A woman who was non-ambulatory, suddenly, but she would bear weight to pivot transfer, and one day she stopped doing that. There was nothing on the history. There wasn't anything on the examination that seemed really helpful except an otitis externa. Not an otitis media that might have given her a balance problem. An otitis externa was all I could find, and thought I needed to treat that. Anyway, treated it, and she went back to bearing weight. Are they related? I'll never know. But I have to wonder, or it's a coincidence. My point, and what's memorable to me about that case is sometimes what to you or I, or even other patients, would be a trivial problem can have a huge impact on somebody's life, and doing something fairly small can really improve their quality of life. And that's part of the fun of looking after people with disabilities. We ignore sexuality, at least often in adults. Epilepsy I've mentioned. And you see here some of the psychiatric guidelines. Again, that baseline, and I'll mention more about this when I come to the tools. We know these psychotropics are overused in this population. So, we have all these wonderful guidelines that physicians are going to ignore, and we wanted to teach people, so we developed tools, and they actually were published as a book. And it was from those that we got a grant here in Tennessee to convert some of them to be made in Tennessee, so reflect things like ADA and so on, and to make them electronic. So we got a grant, the Vanderbilt Kennedy Center, the Bowling Center, and Department of Intellectual and Developmental Disabilities, and we're indeed fortunate to have Janet Schoss, who's here today, as our coordinator to herd us all together and produce the toolkit that arose out of that. We had a self-advocate, family member, medical student, a number of people involved in that project. And most of you should have a single-page handout that lists some of this. If you go to, and again, the general issues, physical health issues, behavioral and mental health issues, something also called health watch tables, which I'll get to in a moment. And there's on the website, so that's what you've had on your table, but that's what you'll see if you go to the website, www.iddtoolkit.org. And what I've highlighted there with the red box is a link back to all the Canadian work. And so the guidelines and some additional tools that we didn't have funding to convert are there as a resource. All of this is freely available and you can download. And you've got the website there. So I want to talk about some of the tools. The first one I want to talk about is communication. And these did not reproduce well, so what you have is you have a second handout with, in the upper right-hand corner, you have hand-numbered pages. And so I want to just show you some of this. So this sounds simple, and of course you can't teach this from a didactic tool, but it's interesting when you're dealing with students who haven't had a lot of experience, that the inexperienced person often will start to shout as if somehow that would make a difference. So that's always an indication of someone who hasn't had a lot of experience. But as you look through those few pages, you see there's some practical suggestions. Things we all know, but sometimes people forget when they're in an unfamiliar situation and dealing with an adult with a disability. And it emphasizes things like concrete language. You know, a phrase like hop up on the scale, taken literally, means something very different if you're used to thinking concretely. Seems simple enough, but those are the kinds of things that confuse the person, and now you've added to their anxiety and they may have more trouble focusing. Something as simple as that instruction you thought was perfectly clear, hop up on the scale. Listening, speaking clearly. There are materials to be able to communicate without words. And then this, of course, was one that's important to convert, and we did, in terms of legal obligations on page 4. There's some resources, and all of these tools were peer-reviewed and went out for external peer review as well. So that's just an example of one of the tools that can be helpful. The second one I've included in your package is informed consent. We heard about that this morning, and it's such a critical issue. What I think is useful in this tool is that not so much the concepts, because in some ways they're the same, but the way it is operationalized in terms of common examples of ways to phrase it and explain it to someone with a disability. Is what's embedded in that particular tool. So it's fairly detailed, and there's also a second page that got reproduced, which is on page 12 and 13. So again, very concrete, practical. Throughout all of this, the people working both on the guidelines, but probably more importantly with the tools, was a multidisciplinary group of clinicians and others, and there wasn't anybody who hadn't at least a decade of experience working with people with disabilities. And we're all busy practitioners. So, you know, having something that's long that's not very workable just is not ever going to be helpful, and you're not going to use it. So to the extent that these could be as compact without missing important issues, that was the aim of developing these. So again, particularly on page 12 and 13, you see some questions laid out there in the context of someone with a disability that may be helpful compared to what you would do in your office with someone without a disability. So now I want to turn to the next one in your package. Should be cumulative patient profile. Again, these are electronic and can be completed. This is a summary. And again, you can take some of this and you may want to think about building it into your electronic health record. But it goes through some key elements that you may not think about for, or at least a practitioner who's not terribly experienced with people with disabilities may not think about immediately. Let me say that two of the first questions I ask at an encounter, two things I want to know right away after just greeting the person, and that's an issue too, and alluded to in some of the tools. People with disabilities complain that often they're treated like they're not even in the room. And when you're teaching practitioners, students, interact with the person first. Anybody there is going to be able to hear you, and if you don't know what the receptive and expressive language of that person is, it just makes sense to interact with that person first. You're communicating a lot, even if they don't understand the words. And then turn to the accompanying person if there is one. So after that initial greeting, I want to know if there is someone with them, how well do you know this person? When I get, and it's almost a standing joke in the health arena with adults at any rate, is not at all. I was just told to drive the van today. I just feel my stomach in a knot because I'm thinking this is not going to be really helpful because I need more history than that. And any written communication's helpful, but it's not like the interaction you can have by talking to someone who knows that person. And remember, often the most valuable information is that there's a change, and that may not be very specific. And soon after that, I want to know, would I know if this person has pain? And they may have caught their finger in a door or had some kind of injury that the person may have knowledge of pain. I want to know what that person's pain behavior is. And if I hear the answer, no, we wouldn't know, I'm just about beside myself with anxiety because I could miss almost anything, but at least I'm now more aware of that because I certainly can miss things on history and I can miss things examining that person because they may not show the same pain behavior. So after that, what other things do I want to know? And they're laid out here. I want to know about the etiology of the person's disability. Unfortunately, if someone's not trained, knowing somebody has Fragile X may not imply very much to me, or knowing that somebody has Down syndrome. You know, it's fun with students to just, and the way we present cases, you know, I have a 35-year-old man or woman with Down syndrome, for example. What are 3 or 4 things you're thinking about? Well, to someone without experience, they're not thinking about anything. And I'm sorry I didn't bring the Down syndrome checklist, but it is there, and I brought Fragile X instead. But, you know, just beginning a differential diagnosis, beginning to think about what things might be relevant here with Down syndrome, heart disease, major depression, thyroid disease, sleep apnea, and on and on. That's before I know why the person's here or anything else. But you've got to know something about the syndrome to know there are certain health risks that you need to be thinking about. That's where the health watch tables come in. So etiology is important. When was the person last assessed? You know, an assessment at 12, age 12, in someone who is now 50 may not be very helpful if they've not had any assessment after that. Where do they live? Who makes the decision? That's right on the front page of this. That's important to know in terms of consent. Special needs. What's this person like in the clinic setting or where you are? We heard a dramatic example of that from the valet parking at Vanderbilt. But knowing those things ahead of time can help you plan. And often the people who present with challenging behavior are on the autism spectrum, and it may not have been recognized. So we're putting someone in the least supportive environment we can because we're not attuned to their sensory needs. We're assuming their sensory needs are the same as someone without an autism spectrum disorder and expecting them to be relaxed and engage in behavior. And that's just totally unrealistic. So knowing those things ahead of time can be extremely helpful. If there are particular triggers, colors or bright lights or whatever can be extremely helpful. And then it goes on for usual things like problem list, medications, and past history, all those sorts of things. But knowing some of those things up front can be very helpful. And that just, I initially thought I could parse these out, but they still didn't project well, so that's why I provided you with the handout. Knowing the level of disability. So if somebody has a profound intellectual disability, what does that suggest? Well, it suggests to me that the person may not be verbal, they may not be ambulatory. I already shared that they have a almost 50-50 chance of having epilepsy. So just those few pieces of information start to set the stage to help you, the clinician, provide better support for that person. And that's just a list of some of the other components of that. So that can be a useful document, or you can take some elements of that, or you might sample some of this for your adult providers you're trying to engage with to take on the care while we're waiting for the buses. And then the health watch tables. Actually, it was interesting, that large developmental center I showed you a picture of, the chief physician there was a pediatrician, although she spent most of her career doing adult care, not surprisingly. And she needed little checklists to put in the front of, in those days, paper charts, because even though she did this full time, she couldn't remember all the various components with all the syndromes. And remember, there was a big population. That was almost like a small city. And so she developed these health watch tables, which have evolved over time into the health watch tables that are part of the tools. And so it goes through, and this one starts on page 19. So it goes through body systems for things to look for beyond the usual preventive care that you would do for anyone. These are more specific to that syndrome. And it works through each system. Some of the information is for children, but predominantly it's oriented towards adults. And again, it's well laid out so you can look at the system. So it's a useful resource when you have someone with a particular syndrome. I want to now turn to the last part of this, and I think the most useful. Oh, here's, if you want to go to lunch early, This is the real quick run-through. And what's interesting, and this is, I'd like to say I'm that smart, but this is just blind luck. Before that first consensus conference, we had a conference of family physicians. And remember, in the Canadian healthcare system, only family medicine is primary care. If you're a pediatrician or OBGYN, you can see my patient without my asking you to and sending back a consult. But if we have that interchange, you get like quadruple what I get. So every other practice is referral. So this was a primary care conference, but family physicians. And I wanted to give people something to take away that was useful. And it was purely based on the experience I'd had. But what's interesting is it sort of stood the test of time. So first thing, you got to blame the drugs, because people aren't going to complain. They're not going to come into your office and throw the pills down on your desk and tell you in no uncertain terms what you can do with your pills, because they're making the point the side effects are worse than what we're treating. If you don't think of side effects, they're going to get missed. And even worse, the side effects might be seen as part of the condition, so the person's now having side effects and you're going to increase the medication because you think the condition's not improving. Constipation, probably 70% of adults. I've had patients die from being obstructed, from being constipated, because I haven't recognized it soon enough, and I know better because I do have experience. Reflux is extremely common. Almost anything can look like a seizure. People who cough and have difficulty eating are easy. It's the silent aspirator, when you see the pneumonia or the recurrent pneumonia, you have to think about silent aspiration. I mentioned etiology. I mentioned sometimes just being different is all the history you're going to get. And if you get it from a reliable observer, that really needs to be investigated. Pain, I mentioned. Sleeping. If I could only ask one question on history, to try to tell if somebody's got something significant going on, and doesn't apply to people who have a tube, it would be, how's the person eating? I find that's quite common in adults with intellectual disabilities related to a number of things. And then, of course, and usually the psychiatrists in the audience have apoplexy when I venture out on this limb, but I'm making the point here that psychiatric diagnoses are not easy to make. It's not easy to sort out behavior sometimes from a psychiatric disorder, and again, easier at the mild end of the continuum, but as you get towards the profound end, it really is difficult because you won't get self-report and other things we go by. But it certainly, if empiric treatment's going to be tried, it certainly makes sense to think about anxiety disorders, mood disorders, before schizophrenia, for example, and lay on another psychotropic, because if 5 are good, 7 have to be better, right? I'm joking. You almost think that when you look at people's medication list, and we know that schizophrenia is probably triple. Instead of about 1%, generally adults with intellectual disabilities, and again, I'm generalizing because we could look at it by various etiologies, it's about 3%. So that's my empirical list. And I can't even be sure. Sometimes I've ruled out a medical disorder. So there's a tentative nature to the care of adults with intellectual disabilities. You're always thinking, I could be wrong. I'm going to circle back. Is the person getting better? I've decided what better looks like before I try my empiric treatment, because otherwise I just reinforce what I'm doing. So I think my plea is to be intellectually honest. So think about drug side effects. Blame the drugs. Part that really hurts with this one is it was a frontline staff person who gave me that cartoon, and I think they were telling me I overdid the laxative orders. But it's a good way of reminding people about how important constipation is, and then reflux, you know. So that makes it easier to remember those big three. So in the just last few minutes, the behavioral and mental health tools, I think, are most helpful because that's where most providers have a challenge. Where do I even start? Here's somebody, this behavior, and I don't really know what I'm doing here. So this particular tool, it's two tools, gives you a structured approach that at least can get you a part of the way. And this starts on page 26. And this is the provider checklist. So it's the same sort of model, but it is different because clearly you're doing something different from the second tool, which is what the person fills out, or the staff person, or the family member. So you'll see on page 27, there's a long list of medical conditions. Again, if the person has a syndrome, a Health Watch table can be particularly helpful, but these are more general. There's, over the page, is problems with supports or expectations. So the model is there a medical problem? Is there a problem with supports or expectations? Is there an emotional problem? And then, is there a psychiatric or behavioral problem? Or psychiatric problem, sorry. So community supports expectations, examples there are things that would be common in people with disabilities. Emotional issues, you're going to summarize as the provider what's filled out on the care provider form, so there's just some space there. And then review of possible psychiatric disorders, again, just space to summarize that and a place for notes. Page 30 lays out a whole management plan. You know, if I'm not experienced, I may not even be thinking about a crisis plan. So it walks me through that. There's a tool that is a crisis plan, which includes both some notes, not in your package, but some notes, the example of the form, and the example of a completed crisis plan to step me through what I need to do, assuming I have little or no experience with this. So on page 31 is the caregiver tool, the companion to the one we just looked at. And so here we're collecting information to describe the behavioral problem in detail. We're looking at risk. Risk is important to know. And then possible physical problems, but not the same detailed list, of course, as the provider. Any changes in environment, again, examples that are common in adults with intellectual developmental disabilities, and then some supports, particularly specific examples there. And so on page 34, emotional issues, common emotional issues, teasing, bullying. Your sibling is getting married, your sibling is going off to school, and so that's impacting you, perhaps realizing that will never happen to you with the disability. And then place, because no form is ever, no form can encompass everything, is other concerns that the caregiver has. If you turn to page 36, single page, entitled Psychiatric Symptoms and Behavior Checklist. There are two things to be said for this tool. It makes the point, as I did earlier, that what you need is a baseline, not a baseline compared to other people in your practice, other patients, but a baseline for that unique human being. And so there's a place there for the baseline against a number of factors. And then the reevaluation, which is the part that's new. Since the Toolkit website has been up, this single tool has been downloaded 90,000 times from over 100 countries, which suggests there's some utility out there for simple tools that can be checklists easily used. I'm not going to tell you about the others. The tools that have been downloaded the most are the behavioral and mental health tools, and I think that's where many of us have the greatest problem. And even if you're experienced, it's a challenge, again, as you think about how heterogeneous this population is, particularly getting away from mild to moderate, people with mild to moderate disabilities to severe and profound. And then the very last 2 pages, actually, was something I found, and somebody's going to say, well, gee, why didn't he spend the time on that? That's obviously transition tools. I included it because it's part of the whole schema and the thought process I've taken you through with the guide, very briefly, with the guidelines and the tools that we did talk about, and there are more that we didn't talk about. But this has not been converted. So I pointed out to you, and you can get to it from the Surrey Place website, that Canadian website, and have a look at it and see if they're useful tools. Some of the things that were mentioned this morning actually are there. But the spelling's going to be wrong on behavior. They may even use the British spelling of pediatrics, so it's going to look weird. And the tools haven't been converted to be made in Tennessee or made in US tools, so keep that in mind if you want to use it. You've got to be thinking about Americans with Disability Act and other relevant pieces of legislation. But I wanted to include it so that you're aware of it and can at least have a glance at it to see if there's anything useful there for you. So this has been a whirlwind tour of the Toolkit. And it's hard to comment on the challenges we have with providing medical care as a system here in Tennessee, and certainly dental care, which we heard about so eloquently this morning. Those are not easily addressed, nor are they things that we're ignoring, but I'm hopeful in one particular way. Some of you may be aware that our lawsuits will finally go away in another year and a half. And so the Clover Bottom lawsuit, which actually is Clover Bottom et al., because it seemed to surprise people that the exit plan filed with the federal court is also going to include Green Valley, but it was including all the developmental centers, not just Clover Bottom. Part of that exit plan says, a number of things on the behavioral and psychiatric side, but it requires that the Department, Intellectual and Developmental Disabilities, together with TennCare, will develop training on psychotropic drugs for their contracted MCOs. And then there's companion training for families, for people with disabilities, independent support coordinators, and others on the use of psychotropic drugs. The part that makes me so excited is we've managed to convince TennCare, and the MCOs are wholeheartedly behind this, that it's really not an issue with the overuse of psychotropics, which it is. But the issue is, and I hope I convinced you earlier, we haven't trained providers very well in providing health care for this population, in particular making diagnoses. And I hope I've tantalized you a little bit to demonstrate how challenging that can be. So what we will be doing over the next while will be training for 10-care contracted MCO providers around healthcare, around primary care, around psychotropic use. So that will be behavioral and mental health care. So we have an opportunity now to address something that every state and indeed almost all countries struggle with, and that's adequate training for physicians, nurses, therapists, others fill in the blank discipline in terms of providing healthcare support for this population when you fall off that cliff like I showed you earlier, because there aren't developmental pediatricians for adults with disabilities. There aren't child and adolescent psychiatrists for this population. However, if we can train those primary care providers and we can get them to see how rewarding and how much fun it is to provide this care and try to address things like reimbursement. I mean, I'm not trying to downplay the other barriers, but this is a huge step forward potentially in terms of providing that training. Now, the buses need to arrive before the training is going to be complete, so we still have a timeline issue, but at least I think we can move things forward in Tennessee. Thank you very much.